Hi, so the second shifting just ended, and now we will proceed to the third shifting or the third module. And the first lectures of this module will be divided into two: the introduction to clinical pathology and introduction to infectious diseases. Introduction to infectious diseases will be given, the lecture on introduction to infectious diseases will be given by Dr. Gina Lino, and the lecture on introduction to clinical pathology will be given by me. I'm Dr. G.A. Espiritu, and for this lecture, our objectives will be to describe how the reference values are established or determined. Identify the possible sources of errors when laboratory results are not consistent with the patient's clinical and morphological findings. And then explain the process of post-analytic decision making. And before we begin, I would like to re-emphasize what Dr. De La Fuente mentioned in his lecture during the introduction to pathology. So basically, um, pathology serves as the bridge or of basic sciences into the clinical practice. And I think this art really captures that concept. This was done by a friend of mine, a pathologist in Singapore, Dr. Luo Yushi. And this represents the role of pathology as the bridge between the basic sciences as well as the um, clinical specialties. And I think Dr. De La Puente also mentioned that pathology is divided into two specialties: anatomic pathology and clinical pathology. So basically, what we have been discussing in the previous modules and the succeeding modules that we'll discuss will be under anatomic pathology. So basically, general and systemic pathology, um, majority of it is under anatomic pathology. So anatomic pathology is the bulk of it would be under histopathology. So this is the study of tissues and morphological changes associated with it, and determining why those morphologic changes occurred. And that's what we've been discussing and what we will be discussing in the succeeding lectures and modules. And another specialty of anatomic pathology would be cytopathology. So if histopathology deals with the architectural changes of the tissues, cytopathology would zero in on the cellular morphology. So even if it is taken out of the tissue, such as your fine needle aspiration biopsy, where you destroy the tissue and aspirate the individual cells, the cellular morphology will give us a clue if those cells have mutational changes that are visible through the changes in the cellular morphology. And lastly, the branch of anatomic pathology is immunohistochemistry. So why is it called immunohistochemistry? Because we use antibodies that are that would bind to certain proteins or antigens of the tissues, and these antibodies are conjugated with chromophores. So these are chemical substances that exhibit colors, and usually the basic color that we use is color brown. So when we use immunohistochemistry, the bound antibodies would be seen as a brown color. So if the tissue expresses that protein, the antibody would bind and it will express a brown color. So that's basically your anatomic pathology, which um, majority of our discussions revolves in. But there is another branch of pathology, which is clinical pathology. In clinical pathology, I think you will encounter this more in your clinical subjects, such as internal medicine, pediatrics, surgery, obstetrics and gynecology, and the other clinical specialties. Because clinical pathology encompasses your laboratory tests. So this would be the most commonly requested would be hematology. So this would cover your complete blood count, your coagulation studies. Okay, so basically hematology is the most commonly requested laboratory tests. Next branch would be another commonly requested laboratory test would be the clinical chemistry. So clinical chemistry encompasses your different blood chemistry assays. So this would be your serum electrolytes, lipid profile, um, total protein, albumin, globulin. What else? This will also cover your fasting blood glucose or fasting blood sugar, random blood glucose, and your cardiac enzymes, and all your blood chemistries, not just your blood chemistries, as well as it will also encompass your um, chemistries of other bodily fluids. So you can also analyze proteins in the pleural fluid, cerebrospinal fluid. So basically, clinical chemistry would um, determine the different chemicals or chemical substances found in all these specimens. And another branch of clinical pathology is clinical microscopy. So in clinical microscopy, basically you're examining under the microscope the different bodily fluids and determine what substances or microbes are seen in those fluids or bodily fluids. So this would encompass your urinalysis. So in urinalysis, there are a lot of uh, there are a lot of um, sediments that you are trying to examine, as well as uh, the different cellular elements, if there are fungal elements, bacteria, or other microorganisms that are seen. So you examine it through the microscope. And then fecalysis will also come in for clinical microscopy, your CSF analysis, what else? Synovial fluid. So the different crystals that are found. So that's basically clinical microscopy. And then another branch of clinical pathology would be microbiology. And this is the study of or identification of the different infectious agents as well as determining their sensitivity or resistance to certain antibiotics. And this will be further discussed by Dr. Gina Lim, no, in her lecture um, on Introduction to Infectious Diseases. And the next branch would be immunology and serology. So basically, immunology and serology is the study of your antibodies that are found in your serum. So the determination of the different antibodies in the different components of your hepatitis, the surface antigens, the core antigens, and the antigens of protein E. So antibodies against those antigens would be determined by your immunologic studies or serologic studies. And lastly, we have blood banking and transfusion medicine. And this section or this subspecialty is the most critical subspecialty in clinical pathology. This is the most challenging because you are administering something that is foreign to an individual, and this might give an immunologic response that may be severe enough to cause uh, fatal consequences on the individual. So we have strict protocols in blood banking and transfusion medicine to ascertain the safety of both the donor as well as the recipient of the blood products. And the emerging or relatively new discipline that overlaps with anatomic and clinical pathology would be molecular pathology. So anatomic and clinical pathology, sorry, overlaps with this subspecialty. And I think I discussed this during my lecture on immunology, but let me reiterate what I mentioned. So in the disease process, as mentioned in Robbins, is that it starts with an etiologic agent. And this etiologic agent would cause molecular, biochemical, and cellular events that would lead to morphological changes. And because of these morphological changes, there would be functional derangements because the basic tenet is that the structure dictates function. And in our practice, so for the clinicians or the clinical specialties, they are given the signs and symptoms of the patient or the clinical manifestation. For us pathologists, we are given the morphological changes. So both are endpoints of certain diseases. And these endpoints would be the start of our investigation on what happened to the patient. So by determining or by grouping or analyzing the signs and symptoms of the patient, we have different hypotheses. And these hypotheses are basically your differential diagnosis. And with these differential diagnoses, you would like to determine which is the most probable cause among these differentials. So you would now request for laboratory tests. And this would be the different cellular elements, your CBC, different chemical changes. So this is where your clinical chemistry comes in, and sometimes molecular changes. Actually, immunology is part of this because you're determining antibodies, which are molecules. And by determining or knowing these changes, you're able to support the most probable cause of the disease. And by knowing the cause of the disease, you know how you will treat the patient. Um, in pathology, on the other hand, um, the we are given another endpoint, the morphologic changes. So it would either be architectural changes in the tissues or cellular changes in the cells using cytopathology. And by um, observing or analyzing these changes, we try to correlate it with the signs and symptoms of the patient as well as the different laboratory tests that are available or the different laboratory information that were given to us. And by correlating all these data, we now have a more accurate um, determination of the cause. Again, this will guide us with our treatment. And basically, these three stages would deal with the different specialties. So here, because of the routine laboratory test, this is under the clinical pathology. Morphological changes would be under anatomic pathology. And the signs and symptoms or clinical manifestations would be the clinical specialties. So this is IM, pediatrics, surgery, and all the other clinical specialties. So now that we know, or now that we are dealing with the laboratory tests, of course, again, let me emphasize that pathology translates your science laboratory into clinical medicine. And basically, laboratory tests are comparison of data. So you compare, you have to be able to know, just like what we are doing in studying medicine, we have to know first the normal so that we will be able to know the abnormal. So this is basically a comparison between the healthy and the diseased individual. So how do we establish laboratory values for the healthy individuals? So first you have to ask, what is the magnitude of the observations or measurements in the healthy population? And how close are these measurements to one another? So this is where your normal Gaussian or Gaussian distribution comes in. I'm sure you have already taken this in your uh, undergrad during statistics, but this is the application of those statistical studies. So Carl Friedrich Gauss in the 1700s developed um, or was able to determine the normal distribution. So he derived this curve from studying the errors in repeated measurements of the same quantity. So he repeated experiments or measuring the same quantity and was able to come up with this distribution curve. And for subsequent studies, validated that this distribution curve approximated errors in scientific measurements extremely well. So the approximation of errors was very good. And this is because the random selection of a population often results in Gaussian distribution. So basically, when they perform experiment, they would be given one value and then another value, and they found out that most of the experiments would have a distribution that is under this curve, this normal distribution curve. And they were also able to determine that in each distance from the mean value of these data points, that there is a standard deviation. So standard deviation is basically the distance from the mean where there is a change in the curvature. So here, if you see here in this curvature, we have a convex curvature, and then you now have a concave curvature. And at this point, there is a change from convex to concave, and this will be the first standard deviation, and each point would be equivalent to the different standard deviation values. So how does this apply to clinical laboratory practice? So in clinical laboratory, we determine the 95% of the central values from a normal population. And this will establish the reference range. So for example, in 85 healthy individuals, they determined the white blood cell count. And they found out that in these 85 individuals, most of them were within the range of 6 to 7,000 white blood cell counts per milliliter or per liter. And the mean value was found to be 6.6. And the standard, if you notice here, there is an approximately Gaussian distribution, but not that perfect. And determining the mean value, which is the average, is 6.6. It's around this at this point. And the lower limit would be 2 standard deviations from the mean value. So standard deviation was computed to be 1.457. And the lower limit, again, if you look at, we said that we are trying to establish the 95% of values in normal population. And 95% would mean that it is within 2 standard deviation above and below your mean value. So here you have 6.6 and you need your standard deviation or the distance from the mean would be 1.457. And because we are trying to determine two standard deviation from the mean value, we multiply it by 2. So 6.6 minus 2 times 1.457, it would be 3.696. So that would be somewhere here. And the upper limit would be 6.6 plus 2 times 1.457, it would be 9.514, and that would be around here. So this area now comprises 95% of your healthy population. So that's how we establish the normal value or the reference range for a certain test, such as your WBC count. So now we have a reference range of 3.69 to 9.51. We know that 95% of the healthy population would have these values. And anything that goes beyond this reference range would either be abnormal or would belong to the 5% of the healthy population that is outside the reference range. So the probability that these individuals are healthy would be as small as 5%. And of course, you can further reduce this by correlating it with the signs and symptoms of the patient, determining the different sources of errors. So laboratory tests alone cannot give you the diagnosis. You need still to correlate it with this different signs and symptoms, the morphological changes, as well as the sources of error during the analysis of a certain test. So why do we use mean instead of median or mode? So the definition of your mean is the sum of all these values divided by the number of measurements. So here, the sum of all these values divided by 85, this would be the number of your measurements. So that's how they got 6.6. And then median, the middle value. So here we have 3 to 11. The median would be 7. So there's a difference. So your mean would fall somewhere here, while your median is 7. So we're talking about healthy individuals. So we need to normalize the data. So mean minimizes the effects of extreme values. So because we are talking of healthy individuals, we need normalization of data. So we use mean rather than your median. Of course, median will be used for those abnormal results that have skewed data. And then mode would be the most common value. And here, most likely the mean is equivalent to your mode, but there are certain, because the most common values run around 6, between 6 and 7. So most likely the mean is equivalent to mode in this case. So now that we have established the normal values for certain laboratory tests, we now want to know if the out of the reference range values would be abnormal or would belong to the healthy 5% healthy population. So the correlation of laboratory results, there are 2 steps in determining if these abnormal values are correlated with the clinical signs and symptoms. Number 1, you need to establish a trend. Don't rely on a single out of reference value. So what does this mean? If you have an abnormal sodium, You don't say outright that the patient is hyponatremic. You need to establish a trend of these different of these out of reference or normal values. And remember, in statistics, the more samples you have, the more accurate your or the more probable your hypothesis is. So it increases the power of your hypothesis. And that's what we do when we try to determine the trend of an out of range values of laboratory tests. Another principle or step that you can use for correlation of laboratory results would be Osler's rule. And this is trying to attribute all abnormal laboratory findings to a single cause. Again, if you recall, as much as possible, you want to narrow down the cause to a single entity. And if you can't narrow it down, then that's when you entertain that there are multiple diagnoses or possibilities or probabilities that this disease is caused by different etiologic agents. Because why do we need to be more uh, meticulous in determining the etiologic causes? Because if you treat the patient with, remember that there will be different treatments for specific etiologic agents, and if not only are you depleting the resources of the patient when you give multiple treatments, you may also subject them to multiple side effects. So you have to be very accurate in determining the cause of the disease. So as much as possible, you want to explain all these changes through a single cause. And if you can't, that's when you try to entertain the possibility of multiple causes. But before you jump to that conclusion, you also need to uh, exclude or rule out the probability of errors in the analysis of the specific laboratory test. So now we try to identify the possible errors of these laboratory tests. So we have three stages or three phases of laboratory tests. Pre-analysis, from the word itself, this is before running the test. Analysis would be during the test itself. And post-analysis would be after um, doing that specific laboratory test. So because of the technological advances and quality assurance procedures, it has significantly reduced the analytic-based errors. So because of this, the major source of error now becomes your pre-analysis. And pre-analysis encompasses different variables during your before doing the test. So this may be patient-related variables, what is the age of the patient, the diet of the patient, when was the test done, because there are certain chemicals, especially the hormones, that are determined by the time of the day. So it may be the urinal, some hormones would follow the menstrual cycles. So at what phase in the menstrual cycle is the patient in? If the patient is female. Another consideration would be the specimen collection. How was the specimen collected? Was it properly collected? Because if it wasn't, then this is another possible source of error. Was there mislabeling? There might be switching of the specimen. The blood of another patient might have been mislabeled. So this would be another source of error, and um, a lawsuit may be filed by the patient because of that. How was the specimen process? Was it centrifuged immediately after receiving? And how was it stored? Was it refrigerated so that the enzymatic activity would be minimized? Or was it stored in room temperature so the enzymes would act on these different substrates, um, affecting its metabolism and therefore thereby affecting the values during the laboratory tests or analysis. So in pre-analysis, let me give you an example. So we know that your cell would maintain potassium intracellularly while sodium extracellularly. So once you extract the blood, this will include your um, cellular elements. So extracting the blood, so now you have in the tube your serum, which contains your sodium, and then your cellular elements, which contains your potassium. And this is driven by your sodium potassium pump, which uses ATP as the source of active transport. So once your ATP is depleted, your potassium would now um, go out of the cell, making your serum potassium elevated. So if you let the blood stand for a while and the ATP is depleted, you would have a falsely high potassium, what do you call this, levels in the serum. So you would have the condition known as pseudo hyperkalemia. Pseudo means it's false, hyper is increase, kalemia is the name for your potassium. So that's one source of error. So you have to know how long or the specimen was stored before it was transported to the lab and analysis was done. Another source of error would be using a very small gauge needle that aspirating the cell would actually produce damage to the membranes. Again, once it is extracted and transferred to the tube, you have a compromised cellular membrane, therefore, again, increasing your potassium falsely. So those are the one of the considerations that you need to possible sources of error that you need to identify. So this will involve the collection as well as the storage. So how was it collected? Was it a very small gauge needle that would tear the cellular membrane, releasing the potassium? Another source of error would be the diet. So if you are trying to determine the lipid profile, So we know that lipid profile would, during intake of your lipids, your triglycerides, your lipids are actually broken down into triglycerides. And this will be transported, or this would be absorbed by your intestine, and then packed into your lipoproteins. So the initial lipoproteins, or the initial, the initial lipoproteins would contain lipids that are rich in triglycerides. And then it would be now be metabolized in the liver, wherein your lipoproteins would contain more of your cholesterol rather than triglycerides. And this will be delivered to the peripheral tissues. And there is a certain amount of time that these chylomicrons would be transported to the liver for metabolism. So if you catch the, if you extracted during the time that the dietary lipids are being transported to the liver, before it reaches the liver, if you, what do you call this? If you extract it, you will have a very high or falsely high triglycerides. So what we do is we instruct the patient to do a 10 to 12 hours fasting, so that most of the dietary lipids that were taken in would have been metabolized by the liver. So we have um, an accurate levels of your LDL, which will evaluate the mutation in your LDL receptor seen in your um, what do you call this? In your familial hypercholesterolemia. Because of the mutation of LDL receptors, your LDL won't be able to transport cholesterol, increasing the level of your cholesterol. And because cholesterol is a risk factor in the development of atherosclerosis and subsequently your coronary artery disease. So that's how your fasting or metabolism would affect your analysis. So again, that would be a possible source of error. Now let's go to the analytic phase. So ideally, the values should have a clear cutoff point. So ideally, a true positive value would be those that have the range value actually having the disease. And then the true negative would be those within the reference range that do not have the disease. But in reality, there is an overlap between these values. Again, we are only looking at 95%. When we say reference range, we're only looking at the 95% of the healthy population. And there's a chance that 5% of these healthy population would have a value that is out of these reference ranges. So this is where it comes in. So here you have the 95% normal population. And then this would be the false positive, which is actually the 5% of your healthy population. Your false negative would fall wherein the patient actually has the disease, but the value is within the reference range. So again, there is another distribution curve for your different for the patients who has the disease. And looking closely at this area, sorry, uh, this is actually this area, right? So you now have the chance to uh, establish or determine different cutoffs. So it will depend on the studies. Sorry, I was not able to mention this. In determining your normal values, you have to validate it using the population that is within your area. Because if you recall that these values will be affected by different factors, environmental factors. So in that population, for example, you have a population that are closer to the bay. So the primary diet would be fish, and of course, the fish would have different protein contents, electrolyte contents. So this would affect the blood chemistry of those populations. So we have to establish the reference values according to the population that you're catering in. So going back, now that you have a reference value or reference range, you now would assign cutoff values. So what values or measurement would be able to differentiate between the diseased and the non-diseased individuals? So this is where your sensitivity and specificity comes in. So for sensitivity, this will involve sensitivity, sensitivity, sensitivity. So this would determine those with the disease that have the range value. So these are the true positives. And specificity would lie here where the normal values are actually patients without the disease. So if you look at this graph closely, if you increase the cutoff values, so for this is for the high value reference range. If you increase the value, you cover more of the actual patients that has the disease. But you also decrease the specificity. So this will increase your false positive here. If you see this area, there is, if you set the cutoff value here, you have a lower false positive. But if you increase the range or cutoff values, you would increase the false positives as well. So increasing the sensitivity would decrease your specificity. The same is true when you increase your specificity, you will decrease your sensitivity. So you want two tests. Actually, we do this in practice. We have two tests that would complement each other. So one test would have, the first test would have high sensitivity. So it will include all the, it will increase the chance that you are, what do you call this? It will increase the chance that you are identifying those that are true positives together with the false positives. So it increases your true positives. And then the second test, a separate test, would have increased a high specificity. So this is usually the screening test, and this will be the confirmatory test. So tests that have high specificity would identify your true negatives. So identifying your true negatives as well as your false negatives. So this will decrease the chance that you have the false positive. So you're actually taking the cross section. So thereby you're increasing the accuracy of your test. So an example of this would be in drug testing, we use immunoassays for screening tests because of its high sensitivity. And then once we determine that these patients are positive, sometimes these immunoassays would have cross-reactivities to other substances. Excuse me. And because of this cross-reactivity, we want to confirm it using a more specific test. So this will be usually your gas chromatography mass spectrometry tests. So this will rule out this will decrease the possibility of your false positives by identifying your true negatives. So complementary two tests, screening and confirmatory, would increase the diagnosis of the patient. So that is your analysis. That this covers the analytic phase. So sensitivity and specificity is important in the analytic phase. And lastly, we now have post-analysis. So in post-analysis, you have delta check. Again, you review your reference range and then determine if the out-of-range value is critical or not. So in delta check basically just means that you review or look back to the previous test done. You review the previous test. Are they out of values as well? So reviewing the previous values would give you the trend. And again, this trend would, as mentioned before, would correlate your values, laboratory tests with the clinical signs and symptoms. And your reference range, this is the 95% normal population. And then the critical value would be how the value that will tell us that do we need to give immediate intervention to this patient. So So when we encounter critical values in pathology, we immediately call the attending physician. So for example, you have a patient that has a hemoglobin level of 3. grams per deciliter. So we immediately call the attending physician that this hemoglobin value is critical and we need to give transfusion immediately. Otherwise, the patient would have an irreversible injury, or worse, the patient may die from the very low hemoglobin value. So, and to determine the critical value, we have to look at the literatures, especially the meta-analysis or meta-analytic studies that would establish at what level do we need to give the intervention immediately. So this is where your evidence-based medicine comes in. So first you have a clinical question, and then you look at the literatures and analyze these information or data if they are if the gravity of the evidence is significant enough for you to consider those information. And what is the conclusion of those data that you were reviewing? And can you apply this information to the individual or the patient? And then once you apply this, you need to determine the effectiveness of the intervention that you gave and monitor other studies that would support this treatment or intervention or diagnostic test. So here is an example. So usually for us to establish an evidence-based medicine, we use the acronym PICO. So we identify the problem, give the intervention, and compare it with another intervention or experiment, and then monitor the outcome. So here in this problem, there is a request to provide diabetic screening tests for employee health fair. So the question here or the problem here is that is a portable glucometer and finger stick blood sample appropriate for the population screening? So the intervention here would be the finger stick glucose. And then to compare it with the gold standard usually, or a more established test. So here it was compared to a plasma glucose determination of an accredited laboratory. And then the outcome, if there is no significant difference between the values of these tests, then we know that finger stick blood sample is enough for the diabetes screening in this employee health fair. But if there is significant difference between the two tests, then you know that you can't use your finger stick blood sample in the employee health fair. Or if you are going to use it, you have to determine or you have to establish a new reference values for this test. Okay, so that ends my lecture. It's a very short lecture. We will go more into details once we proceed with the systemic diseases. And these are my references. Thank you for your attention, and I'll see you in the succeeding modules.